Okay, I see that people are joining in. Welcome. We're not going to get started until about 5:05, so give about an ample amount of people enough time to get situated, grab your snacks, take your final bathroom break, as we're going to dig in deep into some of the systemic issues in healthcare. Again, everyone, we're going to start about 5:05. We're just allowing some of the participants to get settled in, take some of their final bathroom breaks, as we're going to get started in about 2 minutes. All right. Good evening, everyone. Thank you so much for joining us. Thank you, panelists, for sharing your thoughts with us. I am Fred Sims. I am currently the Executive Director of Social Justice for Us, and I greatly bring you systemic issues on tap healthcare. This event was brought to you by Social Justice for Us and our sponsor, Ordoc Brewing. Before we get started, we would like to take a moment to recognize the land we are occupying here in Marquette County For that, I will hand it off to Social Justice for Us Director of Advocacy, Clara Munez.
Thank you, Fred. So today we have panelists and viewers from all different parts of our nation, and while this land acknowledgement pertains specifically to the Marquette County area, we at Social Justice for Us feel it's important to share our history, as well as acknowledge you to look into your own. Our land acknowledgement was written by our local professor, Judd Sorgen, with help of members from the Center of Native American Studies. After Indigenous genocide, removal, and the nightmare of boarding schools, we recognize that we are here on the ancestral homeland of the Anishinaabe people. The Anishinaabe people and their ancestors may well have lived in Michigan for more than 20,000 years. During that time, they have protected and cared for the land and the water and all of the being within. For that, we thank them profoundly. May that their lives be full and meaningful. May they have many children, grandchildren, and great-grandchildren. May their homeland and their rights as guardians and caretakers of the land be fully restored. Social Justice for Us is committing to honoring the Anishinaabe Nation through equality and governance, a commitment to justice, and an enduring care for the land and water of our relations. So with that, I will hand the floor back to Fred.
Awesome. Thank you so much, Claire. Tonight, we have an excellent lineup of healthcare professionals and representatives who will be discussing the industry systemic issues. But before we start, a quick disclaimer. The views and opinions expressed by our panelists are not intended as a substitute for professional, legal, or medical advice, diagnosis, or treatment. We want you, our audience, to know that the views of panelists don't necessarily represent the views of Social Justice for Us as an organization. We understand that the topic of healthcare is extremely broad, and this discussion will not cover all of the complexities within our system. Instead, we hope to provide information on often unequal and confusing systems while starting conversations about how we can learn, change, and grow together. Without further ado, I would like to introduce tonight's panelists. Joining us from Northern Michigan University, nursing student Lauren Bosser. Lauren, what is your role in the healthcare system and how does social justice work intersect with that role?
Hi, thanks Fred again. So my role in the healthcare system, currently I am a student, but it will be a nurse. And then I feel social justice work intersects with this role because nurses are one of the frontline employees in healthcare, and we need to be the best advocate for our patients.
Awesome. Thank you so much, Lauren. Next, we have family nurse, practitioner, and clinical social worker, Melissa Copenhaver. Melissa, what is your role in the healthcare system and how does social justice work intersect with that role? Oh, Melissa, you're muted.
Thank you. Sorry about that.
It's okay.
Thank you, Fred. So I'm very blessed in that I have multiple roles that I have to play in the healthcare systems. I'm a nursing instructor at NMU, a local clinical therapist, and I'm also an early childhood consultant. And I feel social justice kind of threads throughout my roles, from helping to promote diversity in our student population so that we have a more diverse nursing workforce for individuals. And also as a therapist, being able to examine my own implicit bias and kind of work on broadening my experience and knowledge base related to the needs of those vulnerable populations that are underserved.
Awesome. Thank you so much, Lisa. Joining Hannah. Oh, I'm so sorry. Thank you, Melissa. Hannah Harriman, our next panelist. Hannah works for Planned Parenthood as a clinical registered nurse and a community outreach educator. Hannah, the same question for you.
Thanks, Fred. So I've been a nurse for 13 years, worked at Planned Parenthood for 11. I worked in a nursing home setting, hospital setting, and here at Planned Parenthood for the last 11 years, and in the clinical setting, and then also as an educator going out into the community, teaching medically accurate, inclusive sexual health education. How does social justice intersect with that? Well, I do work in reproductive health, which is constantly under attack. Allowing women to control their reproduction is very important. Our clinic here in Marquette also offers medication abortion. We're the only clinic here in the whole entire Upper Peninsula that offers abortion. So we see women from all over the Upper Peninsula and Northern Wisconsin. We also serve LGBTQ plus community where they don't feel comfortable going to other healthcare providers. And I love my job.
Awesome. We're grateful for you. Thank you, Hannah. And joining us from Detroit is Cassie Jones Mcbride. She serves as the Black Organizing Program Manager for Planned Parenthood Advocates of Michigan. Cassie, can you also tell us about your work and how social justice is involved?
Yes, I can. Thank you for having me. I'm happy to be here. So I work within our Black Organizing Program, and the driving theory of change is if we support and uplift the political and social power of Black communities through advocacy, organizing, education, and resource distribution, that we will build an equitable, sustainable, and inclusive movement that centers those who are most impacted and attains reproductive freedom for all. So as we know, Black women have long denied control over our own bodies. We historically don't enjoy access to affordable health services. We have been demonized for our own sexual expression or making other reproductive care choices. So Black people also deserve to live free of violence, and Black women can and should be able to make their own decisions about their health. So state-sanctioned violence against Black bodies makes the promise of reproductive freedom unattainable for Black people. And so for those reasons, we stand with the movement for Black lives and defunding the police. And I work with elected officials to ensure that they protect reproductive access. We know that people who hold office need to reflect the needs of the communities we serve. And understanding that candidates of color face systemic hardships when seeking office, I created a website called ppamplcslate.org, which is brand new, that elevates our endorsed candidates of color so that people can connect with them and our issues. I am the first one to ever hold this role in Planned Parenthood's history, but it doesn't mean that Black women have not been working within this organization across the country. And most of what Planned Parenthood does every day depends on the devotion and contributions of Black women. So we work at the heart of this institution. So my liberation is tied to my work. And so we have to make sure that we have sustainable outcomes no matter where we are.
Awesome, great. That's amazing work, Cassie. I appreciate you. And then lastly, our final discussion panelist is Carlin Rapport, who has been working across the healthcare industry in Marquette for over 6 decades. Currently serves on the Marquette County Board of Health. Carlin, what is your role on the healthcare system and how does social justice work intersect with that role?
I'm a retired speech and language pathologist. My colleague Sarah McClellan and I started the communication rehabilitation department at Marquette General and were part of a development of a rehab team. I found that patients of mine were my patients because of the head trauma that they suffered as a result of domestic violence. And at the time, they had nowhere to go. So I, with many others, I enlisted the help of many to form the Spouse Abuse Task Force. And we worked to develop a coordinated effort to support and protect survivors, provide shelter, which is now Harbor House, and work to bring perpetrators to justice. And that system is still in operation today. When over 3,000 residents in Marquette County were uninsured and unable to afford health care, I was chair of the Marquette County Board of Health. We tried 4 times to establish a system of care to answer this need. And finally, with the help of the faith community, we established the Medical Care Access Coalition, which provided essential health services. We kept our finger in the dike until the Affordable Care Act was passed, and then expanded Medicaid, child healthy families, My Child. These initiatives provide much more care. ACA is now under threat but there is a possibility that it can be improved to lessen health disparities. I'm a public policy representative for Marquette's AAW, a volunteer for Planned Parenthood, and presently vice chair of the Board of Health. I've seen progress in reproductive health care wiped out by the global gag rule and legislation that restricts access to care. I marched on Washington 5 times. The last was 4 years ago. I'm working hard now for the Violence Against Women's Act to be passed. The 2013 version of VAWA gave Native American women a sliver of coverage, but it excluded 3 tribes in Maine and 200 in Alaska. It doesn't cover jurisdictional gaps that leave Native American women vulnerable. And it doesn't cover tribal jurisdiction over non-Native perpetrators of child abuse, sex trafficking, rape, or murder. I've taken the notorious Ruth Bader Ginsburg's advice and tried to look at progress step by step. I thought if we lift children and families out of poverty, then everybody's ship floats. But this pandemic has laid bare such inequities in healthcare for African Americans. And I feel our nation and I myself have been complicit in turning a blind eye to these disparities. I'm just one individual who cares about the health of our community and nation. And I've tried to act as an agent of change for social justice and equitable healthcare for all.
Oh my God, thank you. Amazing work, all of you all. I'm truly touched. Thank you. Now that we have introduced everybody, we will move on to the panel questions. For everyone watching, thank you again. You can send your questions via Zoom or even on our Facebook Live. Regarding systemic issues in healthcare. You can also use the Q&A tab in Zoom if you like. So, the first question to discuss: what responsibility do people have as patients in healthcare systems? In what ways can patients advocate for quality care? Again, what responsibility do people have as patients in the healthcare system? And what ways can patients advocate for quality care? Cassie, we'll start with you. Oh, Cassie, I'm not sure if you're
Yes,
muted.
it helps that I unmute myself before I begin to speak. Well, we know that patient rights are often violated. Coupled with the pandemic, you feel that you have no support. So the common pandemic response is to remove patient rights to lessen liability. So you have to make sure that you know your rights and what you are required and demand from your healthcare practitioner. So historically, Black women in healthcare are not believed. So each patient really has the responsibility to demand to be listened to and heard. We have to demand to be believed. You have the right to restorative justice and mediation to discuss obstetric violence, negligence, and any other harm you have. You have to demand to be equal partners in your healthcare plan and not just a participant. So those are just some of the ways that you can advocate for yourself. It may be difficult with the absence of a patient advocate next to you during this pandemic, but going in there armed with the things that you know for sure you need to have in order for you to have sustainable health care is really important.
Awesome. I love that. You need to be an equal partner. Mm-hmm. I love that. And then I guess we'll move on to Lauren. I would love to hear your perspective.
You said Lauren, correct?
Correct.
Okay. I've definitely gone through this, so this is kind of like a personal question too. What I made sure is just document everything, even if someone wasn't in the room with me. If a doctor didn't want to run a test or didn't believe the certain diagnosis, I would just ask, I would like that put on my chart that you have refused this test or to even think about this diagnosis. You just kind of have to be aggressive in your own care. That I really liked what Cassie said about just being equal and just being there. And it is kind of hard during this pandemic too, when you can't bring someone in your room with you. So
Carolyn, what is your thoughts? I believe you're muted as well.
Sorry about that.
It's okay.
I think do all they can to maintain their health and listen to science and trusted public health messages. Be honest with providers and caregivers, and going into the meeting with like an index card of questions and concerns, so that you make sure that everything that really is important to you is covered in the visit is a help. And to ask questions, you know, why is this test or procedure necessary? What are my options? What are the risks and benefits? And what are the consequences of not doing this procedure? Let your provider know what you hope the outcome of the visit is going to be, and to give a full and truthful history. If information is withheld, then you may not get the appropriate care that you need. So you need to be able to trust your provider, and if you are not comfortable, then you need to seek another. But here we live in a region with healthcare shortages, so good luck with that.
Thank you, Carl, and I appreciate it. And then I would like to hear from one other panelist. I will leave it up to volunteering.
I'll go, Hannah, if you don't mind. I think the only thing I would add is that, I mean, certainly those are all wonderful ways in being an equal partner, but we have to understand, like, in many cases, people are not going to feel safe to advocate for themselves, and making sure that when you are out of that situation, that you find someone that can help you advocate for it, and don't kind of let that situation be like it's in the past, so it's not an issue, but to make sure that you kind of seek out someone that can help tell your story so that it doesn't happen again, and then you might feel more equipped to advocate in the future.
Thank you so much. I appreciate that, Melissa.
That's good advice.
Cool. One of the next questions that we have is, what do you think are healthcare providers' biggest obstacles to providing quality care? Hannah, would you like to start?
I would. I think this kind of goes with the previous question, and I think the biggest obstacle providers have is time. Time to sit with patients and build that trusting relationship, to ask the questions, to establish rapport, and get the information that they need so those patients feel safe giving an honest health history. Why don't providers have that time? There's so many reasons that providers don't have that time, and we could talk for the next 2 hours about that. So I think the reason we can just simplify it and say that's because insurance companies are dictating care, and we get reimbursed. The more patients we see, the more procedures we see. So patients are kind of herded through like cattle. So that's a big system change that needs to happen, but it's really time. I think all doctors, clinicians, nurse practitioners, PAs want more time with their patients. They really, really do. And that's a problem that needs to change from the top down. Also, big obstacles are for patients not feeling safe is cultural and diversity training. Some doctors and mid-level providers don't know how to care for trans patients. They don't know questions to ask or how to offer PrEP or PEP for patients. Staffing is a huge issue on floors in hospitals, to be able to spend time with patients and give them proper care that they need, because hospitals don't have the money to pay for more nurses or more nursing assistants. And then if you think about our region, which Carlin talked about earlier, is we live in an area where we have a lack of primary care providers. We don't have enough OBGYNs to see all our pregnant women. So that adds a whole other layer problems for providing care for patients. Those are just a few obstacles for providers providing quality care to patients.
Thank you, Cassie. Would anyone else? No, I'm sorry. Oh, thank you, Hannah. I was reading the comments. Would anyone else like to add to any obstacles that we see in our healthcare system? Or what do you think some of the biggest obstacles that we see while providing quality care?
I think time is certainly a major factor, but also having a limited ability to connect with resources that are needed in a seamless way. And for example, if somebody needed a nutritionist, because to have that person available, or substance use counseling, or a mental health assistance, and to have someone that is in the same environment, the same building, that there could be a seamless appointment. For us in the UP, it's distance and lack of transportation, and the cost of coverage, and the cost of medication that are barriers to the quality of care that people receive.
Awesome. Thank you so much. I appreciate that.
And I agree with that also, because there's a lot that Carlin said that has to do with cultural, humility, making sure that you have the resources at the ready when talking to your patient, and having the time that Hannah mentioned about being able to, talk to your patient and to get the information that you need to fully care for the patient in the ways that they need to. And that would require a lot of collaborative partnerships with other people in the community that do the work around reproductive justice, water equity, food equity, education equity, all those things that inform the reasons why you come into our facility at Planned Parenthood, that informs the decisions of why you have children or don't have children, or have families that thrive. To have those resources at the ready will be, it's a way of being fully prepared to be of assistance for your patients.
Thank you, Cassie. I appreciate that. Would anyone else like to share before I move on to the next question?
I would just add to, I completely agree with all the other panelists, but I think having more providers take the time to kind of think about what implicit bias that they bring, because I think in the UPA, we have a lot of individuals that don't realize that they have biases related to races or ethnicities or cultures or religions. And I think it's helping people realize that we have to do the work before we see our patients so that we can provide them the best care. And I think in addition, we have a lack in our healthcare system of understanding of the impact of race-based traumatic stress injury. So we tend to see it, we don't necessarily put that in the puzzle when we're trying to figure out how best to help a patient.
Thank you so much for sharing, Melissa. I appreciate it. Moving on to our next question. How does healthcare education address systemic issue within the industry? Again, how does healthcare education address systemic issues within the industry? Lauren, what are your thoughts?
Thanks again, Fred. So currently in my studies, because I am a student, I do feel like it's a little bit too early for me exclusively to say what the education system is doing to address these issues. But I did, after I got this question, I did some more searching. So collectively, it seemed that the main issue for healthcare education was, it was the incoming students coming in. They were resistant to the idea that minorities could and are truly oppressed, whether it be for your race, your sexual orientation, socioeconomic status. And I think that the way that we can address this is by having those uncomfortable conversations. We need to normalize not pushing things under the rug and just pretending that they're not there. As we've seen at a lot of the protests, silence is violence, and that rings very much true in this case. And then, so this question also made me think about how I, as a student, could raise awareness, or what other resources I could offer. And I think the first thing I would do is try to have people look at the resource of the critical race theory. Once I read that, everything kind of made sense to me, you know. And yeah, I think just these studies can be really helpful in addressing these issues in the future. And I also, I do have a lot of hope for the next generation coming in. They seem very active.
Awesome. Would anyone else like to add? I would love to get, yes, Hannah, please.
I just want to add, I know I've been out of nursing school for a long time. I just want to share a story. I went to nursing school in North Carolina at a community college, and most of the people were not white. So white people were a minority in that program. But our instructors had a lot of, as Melissa was saying, was implicit bias. So I think nursing instructors can really, as they're teaching, really put that on their students. So I remember we were talking about trans care and gender affirming surgery, and our instructor was saying that if a patient had that surgery, they would have to just get up and move to an entire different town because everybody would know. In this lecture hall with, I don't remember how many students I graduated with. And I like raised my hand and I was the only one. I said, or we could just treat them with love and acceptance. And she was like, oh yeah. And I just thought, wow, that's pretty amazing that my nursing instructor would say something like that. But I was just thinking about the difference between like probably a nursing cohort at Northern and a nursing cohort at a community college in, North Carolina, that student population would be way different. Also, nobody was, under the age of 25 in that group either. So
I think it's important to identify that we all have implicit biases.
yes, absolutely.
And it comes just from where we grow up, our environment, where we learn from, and then how we cater from those things and stuff like that. So it's important that we all recognize that and continue to do the work that we know that we can do, and could work on the things that we can't, you know what I mean, that we're not so good at. So yeah, thank you, Hannah. I would like to open the floor to anyone else if they would like to. If not, we can move on to the next question. Yes, Melissa.
Something to say.
Melissa, and then Cassie.
As a nursing instructor, I do feel like this is one of my great charges that I have as I work with students. And a lot of it is really looking at our curriculum, looking at our admission policies, and trying to be as inclusive as we can in those process, and looking even at how we deliver our content. So we know Native Americans tend to have a higher rate of diabetes. That's a very simple statement for a very complex health issue that really is driven by historical trauma, governmental policies, and not just the fact that, and social determinants of health, and not just the fact that if someone's Native American, they have a higher risk of diabetes. And so we really have to help students understand the broader picture versus just seeing categories.
Thank you, Cassie.
So, I serve on the Racial Disparities COVID Task Force with the Lieutenant Governor, and one of the things that we are doing is helping to provide the framework for the implicit bias training that's going to be required for all healthcare professionals. But I read somewhere a meme that said, the revolution will not be in a webinar. So we have to make sure that if not, we just don't just check off a box after the training and not revisit the reasons why we had the training to begin with, and continuously try to educate ourselves in the needs of the community.
Awesome. Thank you all so much. I appreciate that. This is great. We're going to give our panelists a small break. We have Dr. Abdul El Sayed. He was not able to attend, but he did prepare a video for us and pre-recorded some of the responses to some of the questions. And I would like to share that with you all now. One moment, please. Groovy.
Hey friends, Dr. Abdul Al-Sayed here. I'm a physician, epidemiologist, and progressive activist. My focus is on the intersection between public health and politics, the epidemic of obviously COVID-19 now, but also the epidemic of insecurity and systemic racism that are affecting our country. When we think about a question like life expectancy, it is a pretty blunt metric that gives us a sense of all of the systems that create access to a healthy life and whether or not those systems are working for someone or not. But across our country, even within our state, we see huge chasms in life expectancy that tell us a lot about the circumstances in which someone lives. Now, the particular cause of death may be different, but it's important to recognize that access to a long, healthy life is a function of all of the resources that go into creating that, whether someone has good housing with access to clean air or clean water, good, healthy food, a place to exercise and walk around in their local communities, different stressors in their life with respect to trauma or the potential of being traumatized, whether or not somebody has a good job that pays them a living wage, or they're worrying about what happens if they were to miss a paycheck and what would happen to all of the circumstances in their life. Overall, those things, they accumulate together to shape differences in risk for a number of different diseases. Obviously, when you're talking about life expectancy, you need to look at the number one cause of death in America, which is heart disease, but also recognize that even when you calculate life expectancy, disproportionately, a death to a child, it factors deeply into the way that life expectancy bears out. Because, of course, for example, take infant mortality. When someone dies before the age of 1, their contribution to that life expectancy rate is so much higher. And we know that death is more common at the extremes of life, early on in life, and then later on in life. And so thinking about how, for example, access to good housing or a good job or clean air might shape whether or not a baby lives or dies tells us a lot about the impact on life expectancy, or the death of 1,000 cuts, for example, of a life that is affected by a large amount of stress, the lack of access to resources that then rob somebody of the ability to provide for themselves and their family, increase the stress in their lives, shapes their access to healthcare. That might increase the probability of death through heart attack or a stroke. And what we see is that across different populations, life expectancy differs based on access to all of those resources and the way that they accumulate to shape mortality at the beginning of life among babies and at the end of life among seniors. And these differences have everything to do with poverty and marginalization. That's why Black infant mortality and Black mortality and Black life expectancy are so different than white infant mortality and mortality and life expectancy. And that has everything to do with not just access to economic resources, which we know are patterned by access to social resources, but also those social resources themselves: power, prestige, acceptance, the small experiences of discrimination and the stress that those cause. All of those things add up to take away the life years of people of color in this country, and that also patterns poverty, which takes away from life resources as well. So all of these together, we need to understand life expectancy as the way that these resources accumulate in a life over time to either portend a long, healthy life or to take that away. I think social justice is really important because our healthcare system is just that. It's a system, and it reflects the beliefs and mores that we hold to in our society. Now, if we believe that healthcare is a human right, then we care more about whether or not people have access to healthcare versus whether or not a corporation can make a certain amount of money off of providing someone that healthcare. And I believe that our morals dictate that every body, every life is worth the same, and that everybody should have access to a long, healthy life in our country. Unfortunately, however, our healthcare system doesn't necessarily pattern those morals. We know that in our country, 10% of Americans don't have healthcare insurance at all. And a large proportion of people, even who have insurance, find it hard to access their healthcare because of where they live and because of the cost of care at the point of care, because of the worry of going into debt to have to pay down a deductible. And so the fight for social justice has to include the fight for healthcare if we believe that the kinds of barriers that too many people have in front of getting their healthcare ought to be something that we take on and we take down to make sure that every single person in our country gets the healthcare that they deserve, and recognize that those barriers are a function of poverty and a function of marginalization in our society. And so if we're focused on the fight for social justice, then we have to be focused on the fight for healthcare too. Medicare for All is what we call a single payer healthcare system. What does that mean? Well, it means that instead of having multiple insurance companies as we have in our country right now, we would have one, and it wouldn't be a company, it would be the federal government. We have a system like that in our country for people over 65. It's called Medicare. And the idea of Medicare for All just means that you would extend it down below the age of 65 to everybody. This has a number of advantages. Number one, you would cover everybody in one stroke. Number two, it would address the broken financial incentives in our healthcare system that turn healthcare into such a profit-driven enterprise rather than a human-driven enterprise, because the government doesn't have an incentive to make money off of you like corporations do, but instead has an incentive to empower your well-being. And then number three, it would reduce costs because number one, rather than having multiple health insurance companies, all of whom have a profit motive, have a CEO to pay, have an advertising budget, for example, you have one insurer, who's the federal government, that doesn't have all that overhead. And number two, that the incentives in our system leave hospitals and providers and insurers negotiating rates that tend to increase because both of them want a bigger and bigger cut of the pie. Under Medicare for All, those incentives go away because, of course, the insurance doesn't have a profit motive. The insurance company, the government, doesn't have a profit motive versus the insurance corporations that we have in our private system now. I think Medicare for All would be critical to offering high quality, affordable, accessible health care for low-income people and marginalized people. Why? Because number one, rather than leaving them to the private market to get health insurance, everybody under Medicare for All is covered. Doesn't matter who you are, doesn't matter what job you work, if you even work a job, that you have health insurance. Number two, a lot of the ways that healthcare has accelerated in costs has left the poorest folks out. And by being able to address the incentives that are accelerating those costs by eliminating the profit margin in insurance, we could reduce the increasing costs that are so onerous for the low-income Americans and marginalized Americans. And then lastly, right now we have a pretty hodgepodge system. And what it says is that different bodies are worth different amounts based on how you're insured. And with one insurance system, Medicare, new and improved Medicare under Medicare for All, that difference in how we adjudicate the value of different bodies goes away. So everybody's body has the same value for the health insurance system, for the healthcare system, and that would increase access to healthcare for folks because now, whereas you're seeing doctors and hospitals moving away from rural communities or urban communities, they have an incentive to move back in because those people have insurance and need healthcare too. Look, the most important thing we can do to take on misinformation is to be really, really good consumers of healthcare information. Make sure that anything you hear that you can verify. Make sure that you are paying attention to reputable sources. Think about who and what experts they're quoting and if those people are even real. And then lastly, don't believe every headline you read. Look at the article, click it, look at whether or not it is internally consistent. Look at where the information is being sourced from, and then seek to validate it. So the most important thing is be a good healthcare consumer, right? And don't just read the headlines, read the whole article, make sure you can verify that information. I think that right now there's a lot of fear and unfortunately misinformants, people who have a lot of money to make, misinforming people. They know that the substrate of what they do is fear. And so we've got to counteract that by being thoughtful and engaged with the way that we get our information, and making sure that we're not spreading unknowingly misinformation, even as we're trying to get the best information for ourselves and our families.
Awesome. I almost forgot to unmute myself. Thank you, guys. And thank you, Dr. Abdul Al-Sayed. Do anyone have any thoughts on what Dr. Abdul has shared with us? You do. You just have to unmute yourself, Carolyn.
Information was pretty complete. Really appreciate his input.
Thank you. Any other thoughts? Lauren?
I really enjoyed his last part about COVID. And I just wanted to add on to that with, we just need to be more mindful about what information we're consuming. And I really liked that he said, don't just read the article, or don't read the headline, read the whole article. I think a lot of people are quick to jump to conclusions from like a catchy headline and then just not read the article, so.
Yes, we call it clickbait.
I also just appreciate the doctor's advocacy. I've seen him in different social justice spaces, and he's always advocating for communities of color in such powerful ways like he did this evening. So I just appreciate his voice.
Yes, he's very, very dominant and very strong in his opinions. And we need people like that, especially in the world today. Okay, would anyone else like to add anything before we move forward? Groovy. So digging right back in, Adul left off on some thoughts regarding COVID-19, and we would like to touch on the topic on a smaller scale. What responsibility do you think Marquette County Health Department or other local health departments have to communities in managing COVID-19? Again, what responsibility do you think Marquette County Health Department and other local health departments have to communities in managing COVID-19? Carolyn, we'll have you begin.
I will quote Jerry Masana, who is our health. He's the manager of our healthcare system for Marquette County Health Department, and he has said that education, case investigation, contact tracing, coordination and distribution of COVID vaccine, coordination with key leaders and large populations such as prison, congregate settings, schools and universities, and ultimately our responsibility is to reduce the spread of disease and save lives. Now, I think the word unprecedented should be banned for overuse over these past 4 years. And yet there is no other English word that describes the challenges that this novel coronavirus has presented to our local health departments. In January, we were aware of the coronavirus and its potential threat, and staff were attending meetings with CDC and other healthcare partners. There were multiple emergency management exercises, but there was no guiding light. There was no national plan from CDC. There was an initial failure of testing on CDC's first round. The insistence that we not use available tests from other countries, and the tests had to be credentialed by CDC, created delays in setting up reliable testing in the US. And when the state labs could perform testing, there were delays in results. and these are still occurring. We have 5 to 6 days wait. And during this wait for results, despite recommendations to the contrary, people are circulating and spreading the disease. Public health messaging and guidelines were promulgated by every means possible. But what was unthinkable is that the public health messages were politicized by this administration, and misinformation was and is believed. CDC and World Health Organizations were undercut, and instead of modeling healthy behavior, people were placed at risk at COVID spreading events. There were shortages of PPEs and test agents. Federal stockpiles were woefully inadequate. There was no national plan to manage the need for distribution of PPEs and equipment, forcing states to bid against each other. The source of PPEs was in China, and materials coming in did not meet adequate protective standards. So our health department vied for materials for healthcare workers in our area. We were calling dentists and auto car repair places at one point looking for PPEs. States were bidding against each other. But we were fortunate that our governor listened to epidemiologists and public health scientists and made her directives accordingly. Marquette County Health Department relayed these executive orders. Our health department served as a resource for NMU, working with their consultant, and I have to give a shout out to NMU for its responsible management during this pandemic. They worked with, we received calls from Harbor House, Jansen House, nursing homes, and individuals. Meetings occurred with and still occur with school superintendents, city, county, and township officials. We work closely with the media. The department worked with the National Guard and also is presently working on contract tracing. Understand that a COVID patient, one patient may have 41 contacts that have to be informed. The staff has begun to prioritize each day's calls, making the most vulnerable contacts first. And we have begun using state tracing resources when we're overwhelmed. But we're looking at the possibility of using robocalls at this point. The delays in contacting those at risk now is frankly overwhelming. And so that we have to ask those with positive results to immediately inform those with whom they were in close contact that they are at risk for COVID. We need to self-isolate and contact their health department provider if they have symptoms. Now, we are presently gearing up for distribution of vaccines and providing information to the public about the vaccines and the need for vaccination. So we'll adhere to the distribution guidelines. It'll probably be well into the spring before the general public has vaccines available. The message remains for this pandemic, in order to get it under control, that we have to stay home, socially distance, wear masks, and wash our hands often. And this crucial recipe is being ignored. People, and especially this administration, did not like the information, and they feared the impact on the economy, and they discredited it. This lack of understanding that the need to control the pandemic needed to be first and foremost, and economic recovery would follow thereafter. From the beginning, misinformation, conflicting messages, and underplaying the seriousness of the pandemic confused the public and undercut public health messaging that was based on science and data. So presently, we in Marquette County, like the rest of the nation, are in an overwhelming state of affairs. Hospital frontline workers are exhausted. Those who have contracted COVID or are testing positive for the virus have to be quarantined. The short staff situation can't be relieved by professionals from other areas because other hospitals are equally experiencing a shortage. We are getting calls from Wisconsin and Minnesota to take patients who cannot be adequately cared for in their home community. The first case in Marquette County was reported on March 24th, 2020. Now there are 2,206 cases and 25 deaths. And here's the bottom line. We have to protect ourselves and each other. We have to stay home, wear a mask, socially distance, and wash our hands. And we have to get through these next few months until the cavalry arrives with vaccines. And then the message will be, get vaccinated.
So thank you so much, Carolyn. I appreciate your thoughts. I would definitely like to extend the floor to anyone else. If they would like to share anything on what you think the Marquette County Health Department or other local health departments or have to communities in managing COVID-19. Yes, ma'am.
I think it's really important for everyone to remember that we live in a very rural area and our health departments are very small. So like LMAS, that's 4 counties and they have 1 nurse practitioner and probably just a couple of nurses to do all that contact tracing. So everybody is very, very much overwhelmed. So we have to take a lot of personal responsibility. So while we think that the health department should be doing all that contact tracing, there's just not enough bodies. So being patient and making sure that we're doing our part to support all of those nurses is really important because they're working really hard right now and trying to do a lot of work with very limited resources and very limited support.
100%. I was a frontline worker. I was just in the activity department at Norlight. So like seeing it affected in like a very like elderly care atmosphere was just something eye-opening, you know what I mean? It's just like going from being able to like see your family member one day and then like the next day not, and then like not being able to talk and stuff like that. It's draining on so many different levels and on so many different people, you know what I mean? It's sad for the doctors because they have no solution. It's sad for the families because they're not able to do anything as well. We're all just stuck in this like complicit place that no one really wants to be. We're all really want to do the work and really want to work hard to solve or at least minimize the COVID-19 crisis that we're all in. So yeah. Cool. There are many this is the next question going to our panelists with Melissa. There are many racial disparities with health outcomes and treatment in the US. Some disparities seem to be a direct result of racial bias. For example, according to a study published in the Journal of National Medical Association, physicians are twice as likely to underestimate pain in Black patients compared to all other ethnicities combined. What is being done in your institution to ensure anti-discriminatory practices?
Thank you, Fred. You know, and I think the numbers of examples that we could state in terms of healthcare issues that are being impacted by racial bias is significant. And for individuals presenting, African Americans can present with the same symptoms as someone who's white in terms of mental health, and they will get diagnosed more likely as having schizophrenia than someone with the same symptoms who's white. So those biases are throughout our healthcare system. And I think in an ideal world, you know, we would have a more diverse workforce in healthcare, and individuals, you know, patients could count on sitting down across from a healthcare provider who was a person of color. But unfortunately, that is not a situation that we have. Our healthcare system is very underrepresented by individuals of color. In my role at Northern, you know, we are looking at how do we encourage students to have diverse students to apply to the nursing program, to help us ensure that we retain them in our program, because we know that for certain populations, there's higher rates of leaving the program. So we have to look at encouraging them to apply, and also making sure that we are putting in a system in our curriculum that encourages them to stay and doesn't put up any additional barriers for them. In my small business at Sunta Integrative Health, we really strive to make sure that our therapists provide culturally informed care. And one of the grants that we have in a consultant role, we are able to support childcare providers to reduce the rate of children being suspended or expelled from that childcare. And that doesn't necessarily sound like a racial issue, but what we know about our population is that for children who are suspended from preschool, almost 50% of them are African American. And similar to the example I gave of individuals presenting with symptoms and being more likely to be diagnosed with schizophrenia, we know that children who are of color are suspended at a higher rate, but they're also more likely to be suspended for the same behavior that a white child might exhibit, but they would be more likely to be suspended. Unfortunately, what we know now is that a child who's suspended from preschool is 3 times more likely to interact with the criminal justice systems in the future. And so we are beginning to see this preschool to prison pipeline. And so that's one of the things that that our program is able to do to kind of help support at that beginning of that pipeline to decrease and support the childcare providers and help them provide a consultative role to kind of help them begin to see where they might be having implicit bias to the children that they are in their care and decrease that risk for them to be suspended or expelled.
Awesome. Thank you. Would anyone else like to share any thoughts? Cassie, I would love to hear from you.
Well, Melissa really touched on all the things that I would have. I mean, I think there's a lot of systemic issues at work, and for any of this to not exist anymore, it takes the dismantling of all these systems of oppression that cause these negative outcomes. And the onus is not on the most marginalized to fix these issues, is for the people in power to be able to understand their role in the oppression and then just dismantle it and destroy it. So yeah, I appreciate Melissa's comments.
Thank you. Lauren, do you see any racial disparities at all as a student? Do you notice it in your textbook or even in class during discussion?
I don't know if in my textbooks, in discussion, I definitely noticed more of an open conversation about just anything with social justice. It's been amazing, especially this last year with a lot of the Black Lives Matter movement coming to light. I think that has opened up a lot of good conversations. I really haven't heard anything negative so far. But yeah, I'm also looking forward to continuing my education to notice that too. So.
Awesome. Thank you so much. Moving right along. According to the U.S. National Library of Medicine, a study conducted in Washington, D.C. showed that 68% of sexual minority youth reported not discussing their sexual orientation, and 90% reported reservations about discussing them with their physicians. What changes need to happen in our healthcare system to be more inclusive to the queer community? Again, according to the U.S. National Library of Medicine, a study conducted in Washington, D.C. showed that 68% of sexual minority youth reported not discussing their sexual orientation, and 90% reported reservations about discussing them with their physicians. What changes need to happen in the healthcare system to be more inclusive to the queer community? Lauren, can you add to that?
Yes, and I'm so excited too, because as a queer person myself, I found this was a problem a lot more in like my high school years, trying to navigate that road and not feeling comfortable in a healthcare situation, like talking to my own doctor. And I think it falls back on the microaggressions that healthcare providers can show to queer people. So the first thing is everything needs to be left at the door about any judgment or preconceived notion that you have about anyone in the gay community. But I did want to add, I think this is going to be harder this last June, the Trump-Pence administration rolled back some of the 1557 rule. So this might make that hurdle a bit harder to jump over. But I think as healthcare professionals, we're here to help patients in that alone at the end of the day. And I think that if we are noticing that in our institutions or in our education, I think we need to be having these uncomfortable conversations. And I took a Native American Studies class this year, and I remember I had to watch some TED Talk, and the woman said, "Panic is not prayerful." So I think if we're having these constructive constructive conversations with each other, I hope that we're able to bring to light what these issues are and that we can get over them together, like as like healthcare practitioners. But I just want people to know at the end of the day, like our struggles are real, and people need to listen to that. So.
Cassie, would you like to add?
I think Hannah has her hand up.
And then I'll come to you, okay?
Okay.
I think in a healthcare setting, like Melissa was saying earlier, like having somebody who looks like you. So making sure educational materials have LGBTQ plus people on them, that paperwork is inclusive, that questions that people are asking are not bias, that we're using people, asking people their pronouns and using them, I mean, I work in reproductive health, so we ask lots of really personal questions about sex and reproduction and things like that. So it's, those conversations come really easy to me. I can talk about periods and reproductive organs all day long. So it's not hard for me, but for a patient coming in, that might be really hard. And I think my comfort with it helps them out a lot. But at a primary care doctor's office, they might not be as comfortable. So making sure that the LGBTQ plus community knows where friendly spaces are is really important too. Planned Parenthood is one. So I think making sure that the place is inclusive is important.
Awesome. So just to elaborate a little more, what does inclusivity looks like inside of a doctor's office or inside of a place that you would go to have some of these conversations?
Well, I know that it will start also with just the language that is used. We're just coming off of Trans Awareness Week and Trans Remembrance Day on Friday, and the issues that and I had a webinar around this very topic of trans people of color. And so the thing that was glaring for me in topics that we discussed is the fact that, you know, when you talk about affirming care, when you talk about care that that affirms identities and welcomes all patients, if you have preventative care for women, and if you don't include trans women, and preventative care that includes prostate screening, cancer screenings, you know, if you have you say you affirm, you know, all men are welcome, but then you don't talk about trans men or men with trans experience, and if you don't talk about pap smears and have that as an option or a referral base for you to give to the people who you serve. We have to really think about what, and then also we always talk about these terms in binary terms. It's either trans men or trans women, but it's never like, what if there's somebody who is non-binary and don't associate with either one? How do you then give care for that population? So just knowing who you serve and being more culturally confident and sensitive to the needs of the community, I think is really important.
Awesome. I saw that Carlin, your hand was up.
Yes, I think setting the stage in an office is really important. I think Hannah spoke to that too, in terms of, is there a all gender restroom available? Are there magazines and posters on the walls that give you the impression that this office is open to everyone? If there are flyers, or for example, that address some of these issues, and asking the question, not only your pronouns, but what is your preferred name, and using that name. So it may be somebody's assumption that somebody's coming through with what you perceive the identity is, but their name is Vivian, and they want to use that name to be used in the interaction. And also being open to who is a medical advocate. It may not be a family member, it may be someone else, a friend or another partner, and being open to that, and visitation. I mean, outside of the COVID restrictions now, but still having who else comes in with you to be the other set of ears, and being open to who that is, are all areas that we can be more inviting to the LGBTQ community.
Yeah, I think it's super important to demonstrate. So if Hannah doesn't mind, I would love for you to pretend to be my doctor, and then I'm going to be a patient, and then we can do it. We can do a few different scenarios and stuff like that. I don't mind being a woman. I don't mind being a trans person. I just love to just like demonstrate what it should look like, so then people can have an idea.
You think I'm good enough at that, Fred?
I think you're going to say that. I will let you lead, hey?
Like at a normal visit, like I would have.
We're at Planned Parenthood right now.
Hey, Fred. So of course, when someone comes in on our intake paperwork, it's or we're not doing paperwork now because of COVID. So our front desk person would ask the patient what their name is, what they identify as, what their preferred pronoun is, and what their preferred name is. So I would have that information already. But Fred, what is your preferred name?
Sure. I go by Freddie or Fred, whichever one. I'm completely flexible. And then my pronouns are he, him, or they.
Great. So in my setting, since I'm just used to asking reproductive stuff, I would ask Fred, like, what brings you in today?
Sure. I would just say, I had a one-night stand. I'm just going to be completely honest with you. I'm not at the point in my life where I think I can have a baby. So I would like to discuss some of my options.
Okay, Fred. Totally putting me on the spot. All right. Fred, partners for you, male, female, or both?
So I am bisexual, so I do have a tendency to sleep with men and women. I can't even talk. I'm a little nervous. Male and female, but I'm obviously pregnant, so I think he's a guy.
And sexual parts for you?
I have a vagina.
All right. And what was the first day of your last menstrual period?
I'm pretty sure that's an exciting thing, so I should like be very.
But you can see how, like, when you're talking in terms like that, you don't make assumptions by the way a person looks.
Yeah, true.
I mean, Fred has a male name and long hair and facial hair, but has a vagina. As a nurse, I mean, you can get really stumped with that when it comes to gender. So those are really important things. And if you ask those questions every time the same way, then it's just normal And people who are cis also realize like, oh, it's normal for people to, my nurse or doctor, to ask those questions because other people exist in this world. So, and I shouldn't make those assumptions either. So it's really important, I think, in the healthcare setting as a practitioner that we don't make those assumptions about anybody. I clearly ask total people that I make assumptions that would go by she, her, hers. What are your pronouns? So they know that it's okay to ask somebody what their pronouns are, even if they probably know what they're going to be. Even though I can clearly tell that somebody has a vagina, I ask them, you know, every single time, just to make that super normal for everybody. Not somebody that I'm not sure if they have a vagina or not. Every single person.
As it should be, you know what I mean? It should just be a normal thing, you know what I mean? We all have preferences, you know what I mean? Some people don't like their names, so like to go by something differently, as you touched on earlier. So it's just important to make sure that we include everyone. I appreciate you being willing to be thrown on a spot like that and allowing us to demonstrate that. Thank you.
You're welcome.
Yeah, before moving on, I don't want to make sure I'm not excluding anyone. Would anyone like to touch on this topic before we move on to the next question? No, we're good. Groovy. Sweet. So according to data for Black Lives, Michigan has the leading percentage to death rate to population ratio for the Black community. As of November 18th, 2020, Black people consisted of 34.33% of COVID-related deaths in Michigan, while their population is only 13.81% in Michigan. What do you think is the most important tool for equity in healthcare? We'll start with you, Cassie.
Thank you. So there were a lot of determinants that played a factor in the high rates of deaths. I lost several people during this pandemic, and I'm still, worried about people who's contracted the virus. So it's really present and really top of mind to people who live in Wayne County, especially. So access to testing and services was really an issue. And there was a demand that water shutoff cease and water restored for people of color to even wash your hands as advised. So if you can't even do the basic things of washing your hands because you have no water in Flint, does it? There is like real issue of having to have just the basic needs met. The fact that social distancing isn't possible if someone in their house has COVID is a real concern. And just when we talk about different parts of the state, there are 800 migrant farms in Michigan. And the social distancing aspect there just is non-existent. So what do you do for that population? So most families have to continue to work in places that don't follow safety protocols and precautions. One of the charges of the Lieutenant Governor's Racial Disparities Task Force was finding sustainable solutions that will last past the pandemic. So the expansion of telehealth services that I'm very happy to say that Planned Parenthood does. And most importantly, bandwidth that supports it is a real factor that we're discussing there. There is a real history of abuse in the medical industry. The innovations that we have in gynecological care is based on the torture of Black and brown women. Sterilization of women in the immigrant detention center in Atlanta was just recently discovered. So naturally there will be a fear and mistrust. But more equitable opportunities happen really at intake, as Hannah and others and Melissa also mentioned. So asking for pronouns and how they identify, asking their faith traditions, because that could impact what dietary advice is given. We know that fat bias exists in healthcare, but we also know that some birth control is less effective the more you weigh. So maybe the weight could be taken after having a conversation as to why weight is needed in the discussion. that day and maybe a factor in administering birth control, it can make the difference to a patient that has historically suffered from fat bias and feels shame because of their BMI. And the first thing you get when you go into the office is being weighed. You feel really, trepidation about having that conversation with your doctor when you didn't go there to address your BMI, but that's what they're going to try to address with you. And also when it comes to just having things in the doctor's office that's affirming, like Harlan was saying, if you have chairs, with no arms, if you have, larger gowns at the ready, things of that nature. Well, I have a base in fat advocacy, so that's kind of something that I'm near and dear to my heart. So I really believe that having those small things that happen just when you come into the health center is really important. If they say that they're Black on the intake form and there's no expansive opportunity to note that they are recent immigrants, their social determinants of health may be different. And so we know that Black women can go to the same doctor with the same health insurance class and medical background and have a higher mortality in childbirth. And it is attributed to racial bias, which takes a deeper dive into how medical professionals have been trained, and if training could and would include cultural humility. So dismantling perceptions of people who partake in sex work is also an issue. Who are seeking abortions, people who are seeking abortions, people who have been abused or perceived to be over-sexualized, especially when it comes to women who have traumatic experiences, or people who have traumatic experiences, and some of the things that are said in a doctor's office, may mimic what the abuser may have said, and releasing, the power that you have in that situation, like getting a pap smear and knowing that you have no control of yourself and of your body in that instance is maybe traumatizing for people. So having that breadth of knowledge is important. So care should not be steeped in the perceptions of what you may feel is better without having collaborative conversations.
I love you. Can I say that? It might be too soon, but your ability to bring in religion and to like touch on some of the less of work because of people and where they stand, it's just the real world. You know what I mean? We have to think about all of those things. We have to think about what are their religions, what is their economic status, and how can I help them get the best care that they can get with my abilities and with their capabilities. I thank you. I appreciate it so much. Would anyone else like to add anything? Yes, Carolyn. Please unmute yourself.
Yes. There are so many factors too. Black women are more likely to be uninsured prior to pregnancy, and pregnancy-related deaths for women older than 30 for Black women are 4 to 5 times higher than white women. And cardiomyopathy, thrombotic pulmonary embolism, hypertension disorders in pregnancy are contributing to these deaths in Black women. Hemorrhage, hypertension are contributing factors in American Indian and Native Alaskan women. The CDC has said that factors that access appropriate high quality care are missed or delayed diagnosis, a lack of knowledge among the patient and the provider regarding some warning signs in terms of, for example, hemorrhaging. And for Black men, frequently they will go less frequently to see a doctor, and maybe their first appointment is in the emergency room or emergency department. And there are factors like not having supermarkets and nutritious foods readily available and affordable. Hospitals in this community might be under-resourced, and the exposure to hazardous waste. We know that there are communities where it's a poor Black community that is the place where a plant with toxins is a factor. And so having to deal with this in addition, asthma. I mean, some of these comorbidities like asthma, diabetes, hypertension, the stress and of just being getting from day to day are also factors that have to do with healthcare.
I just want to just remind you of the question. It's just, what do you think is the most important tool for equity in healthcare?
I think communication, first of all, I think that we need to get some legislative changes to some of these factors that have a tremendous impact on the health of the community. And the biggest tool is communication, and using the leaders in the Black community themselves to say what is going to make the most tremendous impact in change, and working together with them to work toward those changes.
Thank you. I love that. I think, especially the way that you said it too, it's like turning to the Black leaders and listening.
And listening.
Yes, I love that, because for so long we haven't been a part of the conversation. We have not been in a room making the policies that affect us. So I think it's really important that our voices, all minorities, are included in anything. All Americans. Yes. Yeah, great answers, everyone. Would anyone else like to touch on this before we move on? Awesome. With this question, I would like to hear from each panelist. I believe I would like to start off with Melissa. What question should we be asking that we haven't?
Oh my goodness, I'm not sure that, you know, and
It's tough, hey?
you know, and just kind of scanning some of the questions that have come in on the Q&A, I think maybe thinking about what are some specific interventions that can be done either as a client and patient advocating for services, or as a health provider, what are some specific things that we can do?
I like that. Hannah, what questions do you think we should be asking that we haven't? You guys, if you don't mind just typing your question in the chat so people can see it too. Hannah?
I think a good question would be how to use our voices effectively to make change at a systems level. So within the healthcare system, to make good outcomes for consumers. I think that's a good question.
How to turn your voice into power.
Mm-hmm.
Yes.
Right.
Lauren, what question should we be asking? I know, right?
I did prepare this one. I think we need to ask like the question of ourselves. Are we being the best listeners that we can be? And that means like mindful listeners, not what is the answer that we're going to give, but are we truly like listening to every word that people are saying, instead of waiting to give like our answer, our words, hear our voices, and like how we're being the best advocate for our patients. And then that too, how are we raising up minority voices so that they are able to speak and that we're not speaking for them?
Awesome. I love that. Cassie.
Well, Lauren took part of my answer, but I think that we do have to look at the ways that we contribute to oppression. And I think that we all play some role in it. Either we are not finding the way to advocate for ourselves in the medical spaces, or if you are a co-conspirator and is not doing what needs to be done in order for us to have the voices elevated that Lauren mentioned. I think that it's uncomfortable, but uncomfortability eases with change behavior. And as soon as you begin to realize the ways that you affect these systems, and it won't be so hard to have these conversations.
Awesome. Thank you. Carlin, what questions should we be asking that we haven't?
how do we reach people who are tired of hearing the same healthcare message in this pandemic? I mean, really, people are fatigued with this COVID pandemic. They don't want to hear, tell them again, social distance, wear a mask, wash your hands. And yet we have to hang in here. And I don't know how to deliver. I mean, I don't know how we can deliver that message that we have to, as a community, do this over the next few months because the lives of our loved ones depends on it. And how can that happen? I mean, any suggestions?
I think it's interesting because like this was just like conversation I was like having with a couple of friends. The amount of money that we spend on political campaigns could easily be spent on COVID-19 campaigns. Like there's all of these commercials about support local businesses and like Donald Trump and Joe Biden and Black Lives Matters, but there's no commercial about washing your hands or socially distancing, you know what I mean? And like seeing those things should be normal because this is the world that we're living in, you know what I mean? And I commend some of the TV shows that incorporate those things because it brings it to a more broader world view, you know what I mean? Like it's not, I don't think we should distance ourselves from this. It is happening. It is very real. It is affecting people in our lives. So therefore, we as individuals should do some of the things to eliminate that. We're washing our hands, wearing a mask, you know what I mean? If you don't have to go outside, don't go outside. So it's just like the most simplest things in the world seems to be the most controversial, which I don't know, I feel dumbfounded by. So just my little rant, I guess.
Thanks.
But yeah, I guess to answer the question myself, I think some of the questions we should ask that we haven't asked is how does our inner oppression affects the way that we interact with the people in our world? Because a lot of the times the way that we perceive things isn't necessarily reality. You know what I mean? And that's simply because of our implicit biases. We all have a different way, a different lens on the world. So realizing what we bring to the conversation, what we bring to the table, and then asking yourself, what do you want from this? What does resolution or solution or an end goal in this looks like? And then from there, you can gauge your morals, you can gauge the efforts, and be able to communicate all the things you need to in a more ambient way. Cool. We do have a few more questions before we dive into the panel for some of the questions that we got online. I would like to hear from all of the panelists again, and then we'll dig into some of the individual questions that we got. What systemic issues within the healthcare system have you experienced firsthand? Carolyn? Oh, you just have to unmute yourself. Oh, Carol, I think you're muted.
What flashed in my mind was accompanying a friend who needed an abortion, and this is before Roe. And Roe, because Roe is so threatened in our future, that's what flashed in my mind. And she had lost her husband and 3-year-old due to carbon monoxide poisoning, and herself had suffered carbon monoxide poisoning, but she was not able to obtain an abortion in the state of Michigan, even though she had physicians who said that this child cannot survive, this fetus cannot survive. She was like 6 weeks pregnant. We had to go to New York, and she had to pay money under the table in order to get an abortion. And I watched young women from this community who died because of botched up abortions at this time. And when we look at a systems, having a system now where we have Planned Parenthood and we have the ability to have medical abortions, and women can control their bodies and decide if and when they get pregnant, is very essential to their equity, their proceeding as equal members of society. And it's just so important. And I just think that that was a systems failure that I encountered that is now being threatened.
Thank you. I appreciate that, Carolyn. Cassie.
I think the question is, what have I not experienced? I've experienced quite a bit. There's fat bias. I've experienced a number of different levels in caring for my mother, who is transitioned now, but I didn't have any health issues, and her kidneys were failing, and I went to her doctor, who was actually my doctor too, offered to see if I was a good candidate, and without even seeing if I was or any testing to be done, he just was like, no. I said, was it my weight a factor? Yeah, probably. So we're just not gonna even explore that. And so, and not being believed, I had a doctor who was, I have severe eczema, and during this time, it was just really a weird way of it expressing itself, and so it had like caused like deep cracks in my feet, and I couldn't hardly walk. And so I went to the doctor and I asked for a temporary for a handicap pass, because my walk from the parking lot to my job was really long, and it was really, really painful. And I had to keep explaining why I needed it. And he felt that I could just be okay without it. I had to keep constantly explaining. And it wasn't until I went to his partner when he was out and describing the pain that I was suffering that I actually got the pass, and there was no question asked. So, which affirmed for me that I needed to choose another doctor. But there is, my sister's a surgeon, so we talk about this often, about how, the ways that there is just a need for just to be patient focused. There's a lot of things that they have to do to address their own equity, within the measures of health. There's things they have to check off. And so much of it is tied into old racist ideology that they learned in medical school that hasn't really changed. And so just acknowledging that and just reimagining how we do all of this work, I think is really important. But I've suffered all of it.
Thank you. And I'm so sorry. We shouldn't have to. Lauren?
So when I first heard this question, it made me think about the time I went to the emergency department. And I was having like tingling on one side, and I like started having weakness. And so I decided to go by ambulance, but they kept saying, oh, it's probably a panic attack. Like you've had panic attacks before. It's probably a panic attack. I was like, well, I know what a panic attack is. Like, this is not a panic attack. They kept telling me it's anxiety. I always feel like it's written off as anxiety. Well, I ended up having a stroke. And I feel like it comes back down to the women are always anxious. I felt like that was such like an issue, like everything that, a lot of things that I've ever gone through, even before the stroke, kind of just like, you're probably just anxious. So it kind of made me think of that, like we don't really think like how women were being put in like asylums or anything about their anxiety. But I think those issues are still there, Yeah, so it made me think of that.
Thank you. I'm sorry.
Oh, it's okay.
It's not okay. We need to recognize that. Melissa.
One of the systemic issues that I've been working on through a nonprofit called Trace Holistic is the availability of sexual assault services provided by a trained nurse, a nurse who has been specialized trained to address the healthcare needs of someone who has been sexually assaulted. And in our community, the only place that you could attempt to access services if you were sexually assaulted is the emergency department, which has a whole lot of barriers associated with presenting there, having to describe what happened. And often our local emergency departments do not have nurses that have been trained to provide those needed healthcare services. So that is one of the things that our nonprofit is working on, trying to increase access so that a survivor of a sexual assault has fewer barriers in order to access the healthcare services that they need to address what happened to them and to start healing.
Amazing work. Much needed in the world today. And last but not least, Hannah.
The issue that comes to mind is how, to me, how people that carry Medicaid are very much discriminated against and sometimes lied to about things that are covered or not covered. So occasionally we'll get people who come in for IUDs, intrauterine devices, where their other providers will tell them that they're not covered or not covered. And that's just an untrue statement. Medicaid covers IUDs. Those private offices just get reimbursed not very well. So instead of those offices saying, no, we don't get reimbursed very well, so we can't put them in, they're just told that their insurance doesn't cover it, but they do. So we put them in. So that's one thing that I see as a systemic issue. Also personally, as Lauren said, where women are dismissed with their symptoms. I was in the ED once with really bad pain and was totally dismissed and nearly died from an ectopic pregnancy. So that's one thing that, that women tend to not be taken seriously with their symptoms.
And just to touch on it from a personal level, for me, I guess this was like, I just moved, it was like maybe about a few years ago. I didn't have a dentist up here, so I went to, I'm not gonna name them. And they was like, oh my God, you have to get your wisdom teeth removed, and then your wisdom teeth is affecting this, and so forth on and stuff like that. Turns out I do not need to get my wisdom teeth removed. My wisdom teeth are fully grown. They do not bother me and stuff like that. And yeah, they like cornered me almost. It was like 3 dentists and like me in the office together. And they're like, we need all of this. And I was like, it's almost like an intimidation tactic, because I understand that like you guys may need the money, but also understand that this is my body. This is something that like, it does not come from a price. This is something that I'm gonna have to use for the rest of my life. So doing things just because you need money isn't a motive for me. You know what I mean? Like we have to sad, you know what I mean? Like it's so sad that it's become more so of a business than more so of a personal interaction as it should be. But Lauren, I saw your hand. I wanted to acknowledge that.
Oh no, you're fine. I just got excited, or not excited, but the same thing happened to me with the teeth, but I went through with it because it sounded very like terrifying, and I didn't have anywhere else to get a second opinion. I was living in my car. I didn't know what to do. And that's why I have a fake tooth. So yeah, they took advantage of me.
Yeah, I have to say some physicians will do that. But we did get some really, really, really good questions. There was one for Cassie. Why is advocacy and equality in women's healthcare so important? Not only to ask for, but to actively push for in areas like Detroit. What are some of the biggest obstacles? And I can repeat it again if you want.
Well, going to the reasons why it's so important, I just was deeply invested in part of the whole Wayne County canvasser debacle. I was in that Zoom and seeing like the pleas of the community in real time um, changed the minds of the people on that panel to certify the votes that uh, would result in protection of my life and my liberation. So is really important. And I was very much involved in the entire process. I was at TCF on November 4th as an election challenger. I heard people were trying to take away our votes. I ran down there and kind of just moved in position and got in there and started to observe things and hold people accountable. We need to be invested in the process. We need to make sure that our voices are heard and that we're seen, and that we are advocating for not just the way that this affects us, but if you are somebody who does identify as a person of color, you need to advocate for people who are marginalized. You need to make sure that you have solidarity to me and the things that oppress me. You have to make sure that you don't feel whole unless everyone else feels whole too, in every aspect of our existence. So I think it's really important to be heard and supported. And the other part was, what was it?
It was what are some of the biggest obstacles? They name education, funding, etc.
White supremacy is the obstacle. I mean, there's nothing else. That is it. That is the barrier to everything. So unless that is dismantled and eradicated, there is no freedom from any of it.
100%. I can't agree with you more so. I just think we have to really think about like who made the policies, who made the Constitution,
Right.
who made the laws we abide by.
Nothing at all is designed for the protection of marginalized people. Nothing in this country is. We've been fighting for agency and from the beginning, since we stepped foot on this land and as an enslaved people, we've been fighting for agency. So we don't know any other thing but to fight and to and so that's why when people are saying like, they're so pressed about, what the potential for another 45 administration would be, all of this is just familiar fights to people of color. We've experienced it and we keep feeling the trauma of it. It's just not new to us. Just another thing.
Yeah. It's like we get our little wins and then we're supposed to just get hide back underneath our tunnel.
Yeah. None of it, like even after this whole thing and we went to, and Biden was clarified every day as the winner. It felt anticlimactic because it's like, okay, so what does that mean really? Because we have not used to having an administration that focused on marginalized people. Obama was the closest that we came to that. And even with that, there were so many obstacles and white supremacy that was in the way that didn't allow him to do the work that he needed to do. So.
Yes, 100%. This is a question that can go for any of the panelists. Have you been taught any of the eugenical ideology in medical schools, such as stereotypes, Black having a higher tolerance for pain, drugs designs for specific races, treatments you were taught that apply to different races? Basically, to generalize the question, have you been taught race-based medicine? No? Is that a no from all across the board? No? I can say that's phenomenal. We will hope that that would be the case.
It is a requirement in medical school now for training. Training.
Awesome. I know that early on, I don't think it was. I think maybe, I don't want to give any false information, but like early 50s, I think the curriculum was a lot different than what it is nowadays.
I would just say, I think there's still remnants of it. You know, if we think about how we might teach nursing students and say that, you know, this population is at higher risk for, I think, for example, like Native Americans are at higher risk for diabetes. And I think we're beginning to understand that that isn't as simple as saying, like, it's not that they're biologically at higher risk for diabetes. There's such a complex interplay of social determinants of health, historical racism. So I think there was still some elements of that, but I think we're starting to broaden that perspective to be able to understand all the factors that go into what we may have previously said was a biological attribute.
Yeah, instead of it being listed as a fact, it's more so a topic-based conversation.
Mhm.
There's so many social determinants of health that, as you say, Melissa, have some impact on whether a person has asthma or diabetes. You know,
Awesome. Another question was, who can we depend on to find quality resources for healthcare? If anyone would like to answer. Thank you, Carolyn.
I was thinking that, you know, you have to rely on your primary care provider if you know, for referrals, and I mean, do as much research as you can for the options that are available, and as much reading as you can.
I think it goes back to what Cassie said, be an equal part.
Whatever. I think that you can get the names looking for accreditation, for example, and determining what healthcare providers, or that gives you some degree of confidence in seeking out care. There are some websites, I think, that look at reviews of this, you know, this person, and that's some help. It's a difficult thing to go through. It's a difficult thing to answer.
No, 100%. I think it really goes back to what Cassie said. You know, it depends on you being very informed in what type of care that you want and what type of care is provided and is needed for you, and then what's available in that area. And then telling and being an advocate for yourself and letting your doctors know, hey, this is what my body is saying to me. This is what I think it is. Can you help me confirm this?
Yeah.
And if that doctor is not willing to be active, and that means actively listening, actively participating, and actively doing the work with you, then that means that you should probably find a different doctor. And then I wish I'm not 100% sure, and maybe someone can answer this. Is there a way to review your doctors or leave like ratings and stuff like that? Because I feel like that would help a lot. I know that we have like Rate My Professor, and like we do all of these other things and stuff like that, but why isn't there a way to rate your doctor, and why isn't that information broadcasted? So I mean, is there a way to rate your doctor? Lauren?
I think there are, like sometimes on Google, like if you look up a new doctor, they'll have like, it's like multiple websites that other people can review them. But I was wondering too, this is more like a question for everyone also, if like on a per county basis, or like for all of Michigan, I feel like it would be so much simpler to have it all on one like website or one platform instead of having it all scattered around Google or like other search engines. I mean, it can be so complicated. Like if there was like one like easily
website.
What was that?
So if only if there was just one website, right?
Yeah, like one website and it all looked fine, you know, because I mean, the Bridges website is kind of hard to navigate. So I feel like there should just be an easier platform for everyone to find it. Like, it shouldn't be that hard, you know?
Great point of bringing into the Bridges website that a lot of Medicare patients use, you know what I mean? That platform, whether you're using it for your SNAP benefits or you're using it for your Medicare benefits, it's a little confusing, especially if it's your first time and there's no demos that they give you either. So I think, yeah, good point, Lauren. I appreciate you bringing that up.
There's this website that I've gone to, healthgrades.com, and they rate hospitals and physicians. It's not deeply expansive, but
Do you mind sharing it?
oh yeah, I could put it in chat.
Awesome. Thank you so much. I appreciate that.
Mhm.
I think we have a few more questions. One was in the Q&A. What could we do to help understand the value of Medicare for all?
I think one thing that if we're having conversations with people about Medicare for all, is that just really stressing the fact that everybody gets to go to the doctor, every single person, and that you don't have to pay. And that helps everybody from not having to pay a premium. Your employer doesn't have to pay part of your premium. So factories aren't going to move to places where they don't have to offer health care. We can focus on preventative medicine instead of reactive medicine. We can start being healthy at it, keeping people healthy from a young age to old age. And that it helps every single person, not just people who can afford health insurance or people who are poor enough to get Medicaid, and then all those people who fall through the cracks that maybe make too much but can't afford health insurance or don't have a job that offers, I mean, every single person gets it. So it can only help every single person in this country. Every single person.
I love that. Every single person.
Every single person. How can that not be a good thing?
I know, right? There was one more. Oh, yes, Melissa.
I would add too that it really does, we really are going to have to find the language to help people shift their views, because there is this perception in our country that you get good insurance, then you must be valued more, and really stressing that it is a shift in values. And I think we need to commit to that every person is versus allowing that to be a status of, in some ways it's a status of privilege. Like, I have the privilege of going to the doctors because I have a good job with good insurance.
Or it's that I have the privilege to have this medicine.
Mm-hmm.
You know what I mean?
Mm-hmm.
Yeah, there's so many things and so many ways that we can continue this conversation. Sadly, we're almost out of time and I don't want to go over. I want to extend my deepest gratitude to Hannah, Melissa, Lauren, Cassie, and Carlin. You guys, your perspectives, the way that you guys were able to engage not only myself and hopefully the viewers were phenomenal. I want to thank each and every one of you. I would also like to thank Dr. Abdul El-Sayed. His message and the way that he was able to talk about some of the things that he touched on was great. And Ordoc, thank you for your fantastic glass and your fantastic beer. I totally appreciate you. You have been one of our greatest partners since the beginning. So Social Justice for Us wants to thank you. Laura Sabo, excuse me. You have been one of our greatest supporters. I thank you for your efforts on the back end of this and also on the front lines. You and your work has been great. I want to thank each and every one of you ladies. I think you guys are going to be superstars if you aren't already are superstars. I'm deeply fans of each and every one of you guys. I'm definitely going to have to follow you guys on your social media pages. I hope that we can continue the conversation and continue to grow together. Thank you all. You guys have a wonderful night, okay? Stay safe and wear a mask.
Thank you.
Bye now.
Bye-bye. Thanks, Fred.
No problem.
Bye-bye.